Welcome to On Par with the President. Today, I am joined by Dr. Jeffrey Carter. He is a leading burn care expert, professor of surgery at LSU Health Sciences, New Orleans, and the medical director for the Burn Center for the University Medical Center, New Orleans. Not only does he help Louisianans and burn victims around the world, he and his team helped develop a spray-on technology which is reducing hospital stays and mortality rates. Thanks for joining me.
Thank you. It's my pleasure to be here today.
Well, doctor, you have an impressive background and resume in medicine and surgery. Was there a reason that you chose this field?
I had excellent mentors, and one of the things that really made this field attractive is that trauma, and burn as a form of trauma, is the leading cause of death and mortality from age 1 to 44. It's the thing that takes our children from us. It's the thing that also takes young adults, and it's also the leading cause of disability in the United States. So it's an area that needs a lot of work.
It's my understanding that you didn't start your career in medicine, that you actually were a math and science high school teacher. How did that experience shape what you do today?
It taught me how much passion I had for teaching, and that I wanted to do that throughout my entire career. But burns is a numbers game. You calculate the size of the burn, you calculate the fluids that are going in, you calculate the nutritional needs of the patient. A lot of it is very mathematical.
Tell us more about your education. What was your journey like, and how did you become a part of the LSU family?
My great-grandfather actually went to medical school at LSU and was unable to finish his medical school due to an accident. And then my grandfather went to college at LSU and held the track record here for over 20 years and was drafted in World War II, and he never got to finish his LSU experience. And then I actually had a scholarship to come to LSU for college. And then an accident happened back home, and I had to go back home and help my dad start his company and go to college in Mississippi. So I've always wanted to come back to LSU and finish the story.
Well, we're glad you're here. Now, you serve as the medical director of the university's Burn Center in New Orleans, which is a very, very impressive place I've had a chance to visit. Describe what some of the unique services that you provide to the community at that center.
We treat the patient in a comprehensive fashion. So everything that the patient needs, from counseling to nutrition, surgery to rehabilitation, reintegration, we do it all there. We do prevention, education in our community, and it's really one of the few places in America where you can go and you can, on one floor of one hospital, you can have everything you need from research all the way through fancy reconstructive surgery. And it's because of the incredible team that's assembled there, and I really have to give them that kind of credit.
Well, let's talk about innovation. Innovation is a very important part of the biomedical sciences. And you had a chance to be part of a group that developed the spray skin. How was this innovation created, and what's so special about this technology?
A little over a decade ago, one of the departments in the federal government realized that we were very vulnerable as a country to burn injuries, burn, blast, biologic, as we saw with COVID, radiation. So they began investing into different fields, and one of the fields they decided to invest in was burn. And in fact, they've put almost $1 billion of research into the specialty in the last 10 years, which is more than all the other funds added together in the history of this specialty. And so it's been transformative for burn care, and probably one of the things that's been most interesting is the spray skin. It was invented by a surgeon in Australia who I had dinner with last month, and we've remained good friends. And when we brought it to the United States, it was studied from the Department of Defense, but also from a civilian perspective. And those funds were originally brought at my former institution where we began those studies. And when I moved to New Orleans, we brought those studies with us, and we began to continue the studies there. And we knew that there's going to be a really special return in this community, because when we do the spray skin, we not only spray the cells that make the skin come back, we also spray the cells that make the skin have pigment or color. And a lot of the people in our community have skin pigment. And so when they get burned, it's a very noticeable deficit from 30, 40 feet away. And with this technology, we can help minimize those deficits so that they can heal more quickly and heal with better pigmentation.
So can you give us an example of how you've used this technology, the spray skin technology, in helping people?
Sure. So we did a case just yesterday, as a matter of fact. We commonly have people who have burned faces, hands, and what we do is to combine it with standard surgical techniques to reduce the amount of skin that's needed or reduce the amount of pain. We've seen that in our patient population, we get 3 times the number of trauma patients as the average burn center, meaning we get patients with more severe injuries. We admit patients with 3 times larger burns on average compared to other verified burn centers, and we get them out in about a third less time. And oftentimes our patients have less resources than compared to other burn centers. So it's really a game of numbers, going back to that, where we have to cause less harm to be able to help the patient. And surgery is one of those unique fields where you have to assault someone to make them better. So it requires a high degree of confidence in both yourself and the team to be able to make that kind of change.
Well, like anyone who is aggressively pursuing healing, which is what you just described, there have to be some challenges in that where the innovation of the technology is limited and you have to figure out something new. What kind of challenges do you face, and are there any ideas in your mind about new innovations that might spin from the challenge?
Sure. This is where the educator comes out. So the hardest person to teach in the room is not the student, it's always the teacher. And unfortunately, sometimes that is the physician. So it's been hard to teach people to embrace a big change in their practice and to believe in something that they can't see. Because you're literally spraying like what are a form of almost like stem cells for the skin down. And so it's different than putting a graft down. It's the same way if I said I'm going to paint your house, but you can't see the paint. Just trust me, it'll be there tomorrow. It's a big change. So that type of education has been a challenge. And we've been able to overcome that with good evidence, large center trials, and then doing long-term studies and looking to see at the outcomes that have come from that.
Speaking of clinical trials and looking at outcomes, your research spans a few topics. Obviously, the innovation related to spray-on and burn care in general, healthcare economics, disaster preparation. Talk to us about some of the exciting things you're finding in the research that you're engaged in.
Probably the thing that's most exciting right now is artificial intelligence. And I know this is a hot topic for LSU right now. So we have 2 different studies, one that's funded by the Department of Defense at over $9 million, and then an even larger study that's funded through BARDA with an industry partner. And the artificial intelligence is helping us do 2 things. One of them is helping us teach better. It's helping us use adult principles of learning to make artificial intelligence guided education so that learners can have the time in an asynchronous fashion, meaning not in a traditional classroom. The other one is a really exciting technology where it uses visible and non-visible wavelengths of light to very quickly take a picture of the wound and then to determine whether it's going to heal or not heal. In clinical practice, we're able to decide if someone has a heart attack with greater than 99% accuracy in an emergency room. Unfortunately, because you're looking at a burn wound, making a decision and very complex things, old, young, comorbidities, other diseases, location, type of the burn, mechanism, it's very hard to predict. And unfortunately, in about a quarter of cases, doctors make an imprecise decision, meaning they offer someone surgery that didn't need it, or they withhold surgery and delay it, causing more pain, delays, and suffering. This type of artificial intelligence, we've just completed our first large multi-center trial, and with over 240 patients leading over 11 centers, including really a lot of the Ivy League schools, but leading it down here from New Orleans, we found that we had over 92% accuracy with this type of artificial intelligence.
Wow. AI is quite powerful. Now, you mentioned that you're working with really talented people at your burn center. The burn workforce is something that we would be very interested in at LSU. We want to make sure we have great biomedical care. It's also one of your research interests. So what strategies and initiatives have you thought through your research or that come to mind in terms of building a strong and skilled workforce for this field?
I'm very fortunate that I have a great team and great partners. Dr. Phelan, Dr. Shane are just 2 extraordinary people that I'd let them care for me or my family anytime. But that's not like that in the rest of the country. And what we have found, we did an analysis through the American Burn Association, and there's only about 250 full-time burn surgeons of the 82,000 surgeons in the U.S. And there's about 130 burn centers in the 6,000 hospitals. So it's not a specialty that's offered everywhere. And what we've done is to begin to look at, number 1, how big is the problem? What is the problem? And then number 2, how can we help distinguish burn professionals? In other words, if you have a burn injury, you want to be cared for by someone that specializes in this. And so I'm very proud to announce that Dr. Phelan and I just got notified last week that we are now, we've become fellows of the American Burn Association. It's a program that was started to recognize people who excel in education, patient care, research, rehabilitation, and injury prevention.
That's pretty awesome. I know that we're excited that you all have that expertise, but it raises a real question about the rest of the country and what kind of access to care people have that might actually facilitate, better outcomes.
Yeah, you're exactly right. So in the last year, we've been working with different groups to be able to look at big data. So we've been buying large data sets, building data sets from it. And what we're looking at now is how access to care impacts outcomes. Because while there are many health disparities, the health disparities that we should probably be the most concerned about are when we have a time-sensitive illness. And like I mentioned earlier, trauma is a leading cause of death for people 1 to 44, but the other things that are time-sensitive like stroke and heart attack. And so how does access change with those outcomes? And what we're learning now is that probably more than anything else, it changes with whether or not you are seen by that specialist. So what we've done is to, number one, build a large data set called the National Injury Resource Data Set. We hope to work with some of the departments that are actually on this campus that specialize in geographic mapping. And what we're looking at is where patients are getting care. So we're getting data that doesn't tell us who the person is, but it tells us if they had a trauma or a burn injury and then where they got their care. And then later we're going to be looking at the outcomes from that care, both the financial consequences, but also the clinical consequences that come from that, to be able to really try to build a better model. That's going to be several years worth of work, hopefully several supported grants for that work. But it's where our passion is beginning to turn, because if you know how to do it and you know when to do it or who needs it, the question is how do you make sure that they get the access to that care?
You're describing the life of a physician scientist. I don't think many people really understand that life. Why do you think it's important for us to actually produce more physician scientists?
That is a good question. So I learned a long time ago that it's more important to know why you do something than it is to know what you did, because the what will change as technology changes, but the why is what's really important. And what's happening commonly now in medicine is that people are learning for a test or they're learning for an answer, but they're not necessarily learning the why. And so the research is really the why, and that's where the beauty and the exploration comes in. That's where the discovery, the aha moments really come. That's also where you're able to learn how to ask questions and be able to resolve them. So a lot of the push that myself and my partners are doing is to work with our students and our residents. And I'm proud to say that just last week at the Southern Burn Region competition, we had an LSU student who won in the oral presentation category. We had an LSU resident, Anna Garbov, who won first place in the resident competition. Our research associate, who's applying to medical school, came in third place, and then our pharmacist even came in second place. So we swept the awards, but it's really about that mentorship and helping them discover research.
So as evidence evolves, what do you see as the primary challenge in your area of expertise?
Wow. So this kind of gets to where I think my second career is going to come, where I really would like to study behavioral economics and implementation science, because people might know how to do it, but they don't know how to get to they don't know when to do it or how to do it necessarily. So how do you help people make that change? Like we were discussing earlier, when a new topic comes out or a new technology comes out, a lot of that's going to be through really effective education. We're very fortunate that LSU is building a large simulation lab there. They're really reinforcing it. We plan to bring more doctors to that community and do that. We do a lot of outreach and education right now. Education is changing how we do it. We used to do a lot of simulation in controlled environments, and now we're going to the forefront. We're going to where they are. And this started back when I was an intern. We raised $3.5 million, and I built the first little simulation lab at Wake Forest, and then it grew from 50,000 to 1.5 million square feet, and it's quite productive. And now we're doing something similar to that down here. We can't do it without embracing education, but also embracing research. And that's also where some of the DoD-funded research comes in too, where what's the most effective way to do it? Is it a PowerPoint? Is it a tablet? Is it a hands-on trainer? And so we're really learning what's the best way to teach doctors how to learn.
I just have to say this for the record. I try to make the case wherever I go that without research, people will die. They're going to die no matter what, if it's the natural course of life. But in terms of intervening on trauma, without the evolution of research, we're just not going to be as effective. And for many people, research is such an abstraction, right? So I appreciate what you do. Now, I have a harder question for you. It seems like your life is very much immersed in research, teaching, and you're a director, which means you're a leader in a very complex organization. Healthcare is a very complicated financial as well as clinical matter. How do you make sense of all this? How do you balance it all to make it work?
Well, the first thing is having a good team. When you have an effective team, you can delegate and you can know that they can deliver. And I've been very blessed to have that. The other one is that setting priorities. There are things that other people can do sometimes with the clinical care where I need to focus my time administratively. Right now in the United States, healthcare is 20% of the GDP. That means that of all the money that comes in the United States, that it's not 20% is not going to bridges or education, it's going to caring for people. And we've got to figure out a way to make that more effective. And one of the tools we use is looking at value. Nobody wants low value care, and it's one of the few things that everyone can agree on, whether you're the patient, the payer, the provider, the hospital. And when we look at value, we look at, and the formula that we use for this, going back to the math teacher analogy, is value equals quality plus service divided by cost. And so if you increase cost, you got to increase quality or increase a new service. But we don't want to compromise this. And so we always want to have the highest value care we can offer. And that's one of the approaches that we take.
Now, in the evolution of all your duties, I'm gonna really tax you here. I always think the best researchers are the ones who can see the field before things really emerge and find that space. Now, there are some who do incremental work, and incremental work is extremely important, as you know. But if you were gonna project out today, what's the next big space in terms of research in burn care? What would you predict?
What we're learning now is that we can create polymers and mix them with someone's cells so that we can actually create suspensions and cover wounds and heal things that we never thought could heal. What we're learning is that you don't necessarily need hot lights and cold steel like an operating room to heal everything. And this is changing our field dramatically. And that $1 billion that I mentioned that BARDA put in, those things were studied in isolation. And so there's a small group of us in the U.S. that are beginning to put those things together. And when we put that together, the results are outstanding. Things that used to be 30 days in the hospital, we can turn into 3. That's a very different world. And the other thing that we look at with this are the consequences of those actions. In many ways, burn, because it's your skin, it's what other people see, it's how you interact with the world, you feel, you touch. It's a chronic disease, it's not an acute disease, it's not a broken bone that heals. It's something that you deal with from a scarring, from a public, and from a personal perspective. There are scars on the outside and the inside. And so our next step is to combine some of these new technologies, maybe look for some things that are really close in our grasp from a polymer standpoint, but then to look at the long-term impact that they have. Because I think that'll help us economically, that'll help us find the best value in the care, and it'll help us educate patients so that they can make good decisions for themselves.
Some folks would tune in to listen because of your expertise in the area you work in, medicine, research, innovation, technology, and they may aspire to work in those areas. What advice would you have for them if they want to jump in and make a difference in the field of healthcare?
I got lucky in the sense that I identified an area of renaissance, and I got to ride the front of the wave. And I'm enjoying that till today. But most importantly, I found something I was passionate about. And when you have that passion, then the opportunity to look for answers or questions and to solve them is there. And so find what you're passionate about, what's important to you personally. We wrote a paper many years ago called For Love, Not Money. And it explains why choosing careers doesn't always make sense financially if you don't follow the ones that you're passionate about. So please find the things that you're passionate about and pursue them.
Well, Dr. Carter gifted us with this wonderful cup. And on the back it states, "What we lost in the fire, we found among the ashes." That's pretty powerful. Why don't you talk to us a little bit about what that's about? What does it mean to you right now?
So, part of that excellence and having that distinguished team is them being able to get certified. So we had the very first nurse certifying exam for burns. And there were 400 nurses that took it, and only 165 passed. And of the 165, 10 of them were in New Orleans. So something we wanted to do special for all those nurses was to have something made for them that they could take home they'd use every day. And we had that made. And the reason why we put that quote on there is because they see people, patients, who are in their worst times, who are hurting, they've lost their homes, and we have to be hope for them. Hope that their wounds are going to heal, hope that they're going to find a solution to the devastation that they've gone through. And what that cup is there for, or that quote, is to remind us all that it's our resilience that counts. And that, like being a great athlete, is how quickly you recover. And so that's really part of why we put that quote on there.
Well, Dr. Carter, the mission of LSU is obviously teaching, research, service. Some people forget clinical practice is extremely important part of our mission. And today we've got to hear from you, and it's quite clear you're contributing to all four of those areas. And thank you for what you do for the state of Louisiana. Thank you for what you're doing that actually is applying not just in Louisiana, but across this country and in a global fashion. We call that flagshipping up here in Baton Rouge, and you certainly are representing a flagship perspective on medicine and healthcare. Thank you very much.
It's been my privilege.